Hello, I'm Laura Flix. I'm a physiotherapist specialized in vestibular rehabilitation. So today we're gonna talk about the physiology implied in this vestibular rehabilitation process. To start, I would like to start with the exercise of Kathor and Koski in 1940 approximately. That's very interesting because they were just starting this entire world, but they already talk about spontaneous recovery, physiological exercise did by a physio, a mental exercise that will be similar to psychology, and also occupational therapy for all the translation of these improvements to daily activities or the adaptation, etc. And also they talk about the early treatment, the necessary rest of the patient, and a progressive evolution. Those are things that nowadays is still being very important, but the thing is that right now we have deeper information about exercise physiology and motor learning, balance physiology, and all those implications in gaze stabilization, for example, for the cognition, etc. And also much information about how the pathophysiology goes and its recovery too. So those are the three main parts implied in vestibular rehabilitation. So we're gonna go step by step. Let's start with the exercise physiology and its implication in vestibular rehabilitation. So we're gonna talk about the exercise a little bit in general. First, because it's interesting to know that we are going to have the side effects that we want for the improvement, but also we will have side effects that maybe will be quite good, as increase muscle, increase the force, increase the resistance, or other things, but also we will have adverse effects in those patients that exercise have. And it is interesting to know specifically for the indications and the contraindication of these treatments. So to starting summarizing a little bit what is exercise, we're going to talk about exercise as a stimulus that it's going to have a diverse physiological reaction. So we're gonna have the neuromuscular ones, we were gonna have metabolic changes, we are gonna have cardiorespiratory changes too. And it's very difficult to have a view of everything because it's something that we could be here talking for hours and hours. And also with this stimulus and this physiological reaction we will have different things in the immediate effect, in the delayed effect, and also different in long term on the accumulative effect. So we're gonna just have the main points of the typical things that will always happen, but of course it will depend in a lot of different variables too, so it's very complex. We will have like the highlights better here. So we are gonna start with the immediate effect, that the effects we will have the hour, 2 hours during and post exercise, where we will have the reduced neuronal activity as a symptom of the fatigue of the central nervous system. We will have increased the serotonin levels, what will increase the tolerance to discomfort of pain of the patient. That's quite interesting. And we will of course use the substrates for this energy, like phosphocreatine, intramuscular glycogen, etc., or GLUT4 in the case that we don't have the energy in this muscle. And we will have the impaired holding of calcium by the sarcoplasmatic reticulum, so we will have fatigue not just muscular but also neuromuscular. And for those mechanisms of inorganic phosphate, it will be the reduction of the insertion force of the cross bridges, and all these consequences in this 1 hour or 2 hours that we will have then the delayed effect that will last 24 hours to 48 hours, sometimes even maybe better to 36 hours. And in this situation, we will have implied the cyclical strength shortening, that it's called, where we will have alteration in the electromyography data. We will have also the reduction of muscular maximum contraction, and so we will have less force. And of course, this increased energy consumption at rest, because we will be in an anabolic phase where all the tissues are trying to readapt to this stimulus, with protein synthesis, with the thermogenesis of the hormone thyroid, with sympathetic nervous system activations, etc. So this way we will try to restore the ATP deposits. So these stores and the stores of the phosphocreatine may even increase above normal in this situation. And with all of these, in this process of readaptation, we will have an excess post-exercise oxygen consumption. So this fatigue that will be in a lot of different parts of the body or of the mechanism can explain the increase in symptoms sometimes that appears in the patients that are in vestibular rehabilitation, that are lasting the 24, 37, 8 hours after these exercises, not after the sessions. But then we will have the long-term effects, the cumulative effects after these 36 hours, 72 hours, where the strength will return to normal levels, of course, and the glucose in the stores will be completely replenished, no? And the most important part, or the part that it's interesting for us, that will be the specific supercompensation. So it will be similar like this, like when we have a stimulus done at the start of one session, during one session, then we'll have a fatigue. Well, the performance is going to be reduced, not just performance as something like sports, but a performance just maybe how the balance, of course, is performed. And then we will have the recuperation part and the supercompensation, where the performance then will be higher. No? But then if we don't do more, then there's a reversibility of these improvements. But the thing is that when we do several series of exercises during the days, we are trying to have the supercompensation positive a long time, where this reversibility doesn't appear. We are gonna have different supercompensation a long time, having finally along days improve the performance. No, it can be done even better if the timings are perfectly done, but if we do it wrong, we start doing maybe too fast the different days with the sessions, we will have a reduction in the performance, because we are going to do the stimulus in the recuperation part. Well, the body isn't prepared for another stimulus, so then it won't benefit in this case of the patients. That's true that sometimes there's a cumulative effect if we do like several days with very followed stimulus, but this is something that just people who perform in sports are really used to that, and they are going to be able to do that. But in patients, these cases isn't the important theory. It will be very much easier to adapt it with the normal model, as to say, no? And if we last maybe too long, that's also true, that we won't have maybe the accumulative effect, and we won't have the improvement in a long-term situation, no? So to continue, I would like to explain it similarly, but with the threshold law. Okay, the threshold law says that you need a minimum of intensity in this stimulus to start having changes, no? It will be weak stimulus to have it lower, because body won't try to make any change if it's not the intensity is not enough. But if we do too much, we will pass the tolerance threshold. So the load will be too much height, and then we will be in an excessive stimulation situation, and probably the patient won't be safe doing those exercise. Maybe will have more side effects or more fatigue, etc. So we are gonna search for the optimal stimulus in the rehabilitation process. Similarly said, it's the balance theory between the load and the adaptability of the different tissues that we're gonna talk in this talk. But the load have to be lower than the adaptability to be able the body to make those changes and make the improvement that we are going to search for. So to create these changes, the dosage, we have to take into consideration the volume of all the exercise, the frequency and the rest of those exercise, intra-session and also inter-session. To say it's different to rest more or less between exercises, and also it will be different to rest more or less within sessions. And it will depend a lot on the type of stimulus and the type of tissue. If for example musculoskeletal, it's a little bit easier to understand. Muscle will be faster to adapt than bone, so the frequency and the rest will be different, and of course it will be different to stimulus the muscle with weights than just maybe jumping or running or wherever, no? So those are things that we should take into consideration. We are talking about dosify exercise, but all of this theory how can be applied to vestibular rehabilitation. So when we are talking about vestibular rehabilitation, we are talking about the tissue that is nervous system. So we're gonna talk about these adaptations in neuronal plasticity and consequently in motor learning. So as you can see in this paper, we have improvement in the cortex area of, well, that's in animals, but we have a higher, bigger cortex area of the hand if we do a task where hand motor learning is improved, no? So we're gonna have changes in humans in a lot of different areas that are all implied in this activity. For example, for motor learning, we're gonna have changes in cerebellum, in motor cortex, in somatosensory cortex, etc. But regarding balance specifically, as we are talking here about vestibular rehabilitation, we're going to have balance that balance training in healthy population will increases cortical thickness in the visual and vestibular cortical regions. That it's very interesting to know that we are going to make changes also in our patients. So, how will threshold law applies in this situation? Well, we are gonna tell that the current the minimum threshold, it's wrong there, will be the minimum amount of exercise, the minimum difficulty and novelty of the exercise that we will apply to start making these changes in the central nervous system. And we are talking about the tolerance threshold. We are going to talk about too much fatigue or the appearance of adverse effects of those patients, no? And all of these will be different depending on the previous experiences of the patient. If they were used to do exercise, if they were active, they will have different levels of these thresholds than if they were sedentary, or also other variables, that age will be different. Children adapt very, very fast. They adapt faster than the main adult, or it will be also, of course, the main adult faster than another older adult, no? It will depend also on the pathology. The physiology will maybe alter this capacity of improvement and will change those thresholds, and also the comorbidities that a patient will have will also affect these thresholds and the way that we dosify the exercise. So to create those changes, but long term, that will be a consolidation of the learning, will be resistance to interference from other tasks over time. We can take into consideration several points, like the repetition within the same session will be important, and doing long breaks also will be important, because this way we are taking into consideration the fatigue and the adverse effects that we talked before. This way we will have bigger changes or longer changes in the central nervous system. And also, if we increase the task variability, it will help the motor learning process, and even do it all the exercise in a random order of task. It will also help. That will be similar as we talked before about the novelty and the difficulty, that minimum those that we need to change, not to make changes. And also will be important the feedback that they receive of this exercise to make bigger effects in a long term. So to summarize all these implications, we will have 10 principles that are described for neurological rehabilitation. But of course, besides they are described for neurological rehabilitation, it can be applied. They can also be applied to vestibular rehabilitation. So the principle 1 will be use it or lose it. If we don't use this new ability that we have learned with the motor improvement and all those changes in the central nervous system or the peripheral nervous system, they will be finally disappear, no? The principle 2 will be use it and improve it. If we do it, if we use it in our daily activities or in an exercise that we are doing in vestibular rehabilitation or at home or wherever, we're gonna improve it. And this connects with the principle 3, that specificity. When we do something, we improve in that point specifically. It's like if we are training balance in a specific situation, we wanna improve this balance in that specific situation, and maybe not in another different situations, no? And then we have the principle 4, that's repetition. We should repeat the exercise to make those changes long term, as we said before. And it will be very interesting in rehabilitation to repeat exercises long time, no? Then we will pass to principle 5, that it's intensity. We need those exercises that be enough intense, that we had told before, to make those changes, no? And besides all of this, the principle 6 is that we need time. If we don't have time, it will be difficult to make those changes. Besides, we have all the stimulus once, the perfect stimulus. We will need time, weeks, months even, to make those changes appear, no? Specifically if we are searching for those changes to maintain in a long term. And then we have the principle 7, that's the relevance. The action should be relevant to the daily activities or to the objectives that the patient have, to be maintained in the time, because they're gonna use it, they're gonna be more motivated, of course. And finally we will have the part that use it and improve it, and use it or lose it, no? And then we have the principle 8, that's the age. As we had said, with the age the motor learning is going to be different, so we should to take also into consideration when we are choosing how and when and etc. We are doing the rehabilitation process. And then we have the principle 9, that's the transfer. As we say with the principle 3, if we train one thing, we're gonna be very good at this specific thing, but maybe we will have also a little bit transfer in tasks that are similar, but not in everything. To say, if we play tennis, we will be quite good also in another type of exercise that are with the superior extremity and all those things, but other exercises that are very, very different of this will be more difficult to be good at, no? And that goes also in the hand with the principle 10, that's the interference. If we train a lot of different things, it's more difficult to be very, very good at one of them. This principle, it's maybe sometimes less important in vestibular rehabilitation, because we are going to search for a good balance in a lot of different situations and not just in one, so it's more important the transfer. But if we want, for example, to be improve in a specific variable because we know that it's important to, for example, reduce fall-off risk or whatever, we will have to take that into consideration because we will like to improve that specifically, no? So with all those principles that are going to adapt in every rehabilitation process, depending on the patient and the situation, one of others are going to be more important or less, no? And it will be challenging to have a balance between the time, the repetition, and the intensity of those exercises. But also, in another hand, we will be a challenge the balance between specificity, transferation, and interference of all this learning too, no? So regarding all those changes that the exercise can do, we're gonna see how it can be applied in the physiology involved in balance, no? Summarizing or making it a little bit easier, in balance we will have the part of detection of the environment with some static information with vestibular and visual. Then the processing, that we will have integration and interaction, having finally the action of the balance or whatever, where variables as structural biomechanics or the muscular tone can also influence, no? But regarding the processing, we will have the integration and the interaction. But the interaction will have inside the integration, because we need the integration correctly to have a good interaction, no? I divided the interaction in the proactive balance and the reactive balance, okay? And then we will have the static, but the static will be a balance within proactive and reactive, because we are never totally static, no? So in the proactive part, I would like to emphasize the integration part, because we need to know where we are, our self-perceptions, and then we will have the motor planification, no? And then in the reactive balance, we will have all the changes that goes after the action, that will be more or less, to simplify, vestibular reflexes and the postural realignment, okay? So then inside the integration, we will have the orientation in space and the self-perception, and inside the orientation we'll have a lot of different things to take into consideration. That would be spatial navigation, spatial learning, spatial memory, the object recognition memory, etc. But the most important part for the vestibular rehabilitation is the self-perception, when we will have, well, the self-consciousness and the perception of the own movement. That will be the most important, the most interesting point. So to make it this scheme more apply, we will have with the vestibulocular reflex, it's a typical schema of that semicircular canal that has the detection part, then the procession is all the mechanism what we know about vestibulocular reflex, and the final action will be the gaze stabilization, that it can be measured with visual acuity. But also we will have the otolite organs that will detect, and we will have the process of vestibulospinal reflex, and we will have the contraction of the stabilized muscles. But the thing is that when we are in the balance part, it will be more complex, because all the detection, all the information that it's going to start with the semicircular canals and the otolite organs will interact a lot in the self-perception, the postural realignment, and also the orientation, to finally have an output that it's balance, no? So just to know a little bit how complex can it be, I would like to emphasize the cortex areas that have vestibular influx, some of them, no? For example, the most important will be the parieto-insular vestibular cortex, where we will have the egocentric representation of the person with also proprioceptive stimulus, and it will interact the body movement in reference to vestibular inputs. But for other part, we will have the anterior parietal cortex that will differentiate one's own movement with respect to objects, and it will integrate sensory information from head, neck, and upper extremity. So it will be another different point, for example, to take into consideration. And not just the own representation, but also the spatial representation, differentiation, the movement itself, and the states of acceleration that will, for example, integrate vestibular and visual information mainly in Brodmann area 37. And also we will have the retrosplenial cortex that will change from egocentric to allocentric, so more first person to third person view on our brain, or even more complexity we will have, if it's possible, in the hippocampal and parahippocampal cortices, where we are going to integrate cognitive maps regarding to spatial memory, regarding information about the past, and navigation planning regarding information about the future. And this connection of the vestibular system with the hippocampus will be in a lot of different, well, four type different of pathways. So we are going to have a lot of different variables that are going to interact to finally have this part of processing that we were talking before about orientation. But at the end, when we are trying to understand this in clinics, or more take it to a functionality part, we simplify this, saying that we're using more visual or more vestibular information or more somatosensory information, depending how we react in those different situations, no? But the thing of this is that this is always changing. This is different from the person, from the previous experiences, etc. No, so it's a process of sensory reweighting according to the task. When we are maintaining the balance in a challenging sensory environment, a non-pathological person, we use more visual information than vestibular and somatosensory, and it will change when it's not that, when we are relearning the situation, and we're gonna use, for example, more vestibular information to maintain, no? And it's something like it's dynamic and it's always changing. And regarding this, when we are talking about more reactive balance, when we are talking about the postural realignment, it will be even different if the movement is more horizontal or more vertical. So with horizontal translation of the platform force, we can see that if the movement is done in 80 or 100 milliseconds, it will be more somatosensory information, and in 200 milliseconds then we're going to use more visual information. And it's going to change, for example, if we have a peripheral neuropathy, because this reaction will be longer because it's not that fast, the connectivity, no? But then it will be different if the this case will be, for example, if we're walking and then we sleep, or we are walking in the ice, etc. But it will be different than movement in vertical, where we are going to use more visual and vestibular information that's measured with the toes up and toes down test, for example. But will be in daily practice, I don't know, going upstairs or something like that. And if we are doing with eyes closed, will be totally information, well, almost totally vestibular information that it's going to change, no? So how can we try to interpret all this knowledge about balance, about motor learning, when we have unilateral vestibulopathy? So we are going to talk about central nervous system compensation, no? It will be the term was used to define the phenomena that occur after this vestibular unilateral vestibulopathy. But it's a term that it's very used in acute and subacute injury, because it's the easiest way to research it and to, of course, research about this part. But it will be extrapolated more to an uncompensate situation, or the progressive appearance of this vestibulopathy, or a chronic onsets, etc. No? So, how does the motor learning will apply in these situations? We will have the compensation, the habituation, and the substitution parts that we more or less know in the literature, but I want use these terms along this talk because I want to be a little bit more specific and not try just to talk that it's habituation and substitution more generally. So I'm gonna focus in the specific physiological mechanism, and as we all know, it's very defined what is going to happen with vestibulocular reflex and vestibulospinal reflex, but not that much about the balance system. So just to start, I will start with the vestibulospinal reflex just to know where we are. This otolite dysfunction will recover faster than the canal-related function, and it's true also that the level of this dysfunction is not a predictor of symptom recovery, so it won't be the real focus of vestibular rehabilitation. And it's also true that it reduces with the age, so it will be also a natural evolution to have less functionality of this reflex. But then we have the vestibulocular reflex. Well, we have the static nystagmus that will be also naturally reduced, but not that good is going to go as a natural evolution. All these variables related with the vestibulocular reflex, as the head shaking nystagmus, vibration in the nystagmus, and the caloric test and the head head thrust test, and those are going to be better evolution with rehabilitation, no? And in this case, what we are going to search for is that this corrective saccade, this movement of the eye, that it's going to be late for the head movement, go with the time at the same time of the head. Those changes are produced in different parts of the cerebellum and the brainstem, and that is why the affectation in the cerebellum can affect the evolution of vestibular rehabilitation, and that's a point that we should take into consideration. The thing is that in the cerebellum, the parallel fibers will have information in the Purkinje cells about age and head movements, and the climbing fibers will have info about the image movement that come from the lower lip. And finally, this interaction of information and the displacement of the image on the retina goes to not a good stabilization, will give enough feedback to improve this through these cells. And these changes, this contribution of the cerebellum in the follicular lobe, it will make changes in a short term to improve this reflex with the long-term depression. But the thing is that this change will connect also with vestibular nucleus plasticity that will have the improvement in a long term, this motor learning long term, and it will be also help with head and visual movement at this point. So this way we will have that these saccades are going to be more accurate and more organized, that it's also followed but functional improvement that can be measured in this case for the dysfunction handicap inventory. And we can see that it improves it goes with improvement on functional, emotional, and physical discapacity. But when we are talking about the balance, we're gonna start having it a little bit more blurred, no? So then we will have affected the proactive and reactive balance. It will be hypermetric or reactive and anticipatory postural response. We will have an ataxia, and that will be caused with the loss of vestibular inputs. So this way we will have an inhibition of the spinal motor system. and the reactive sympathogenesis of somatosensory inputs. To have it a little bit more easier schematized to say, we will have normally a central order in the nervous system for doing an action, for motion the limb or wherever, that goes at the same time with a postural adjustment with the proactive balance to maintain it correctly, and then maybe this motion will have a postural disturbance that will give a feedback, a reactive. We will have the reactive balance, no? But when we have a lesion, an acute injury, this central order will send this action of motion, but won't have a correct postural adjustment. So we will have a bigger postural disturbance that will come with this hyperreflexia that we have been talking about. And this situation, we will need a bigger postural readjustment, but this postural readjustment will come also with a feedback to the central order. This feedback can be used for improvement the initial information that we should currently have about this postural adjustment, so we will have the sensory reweighting according to the task that will help to have this proactive balance better, no? And it will happen in a lot of different contexts, and here it's where the principles of specificity, transfer, and interference of the motor learning will be more important. And then that it's true that there's a part of the patients that will be interested to know very specifically who goes better without doing anything, because the natural evolution is very good, and who will need to do a vestibular rehabilitation. But sometimes they are not going to go perfectly good by itself, so it's the important point to know where to set vestibular rehabilitation, no? So in this line we have the predictions of the central nervous compensation, and as we told before, the principle of age is very, very important, because there's a literature that says that age has worse evolution, besides others that says that theoretically age is the same evolution if we see it longer time, because they need longer rehabilitation, because the motor learning process is slower, as we have been talking about before. And also in the same line with, well, the changes in brain white matter, of course, is gonna go in the line that they will need more rehabilitation, they go with worse, no? Also, it will affect the different levels of injury, because they will get to different degrees of recovery. If they had bigger lesion, bigger discapacity, it will be more difficult, of course, also to return, because we will have less functions maintained. But it's not just about this improvement in vestibulo-ocular reflex, it's also about balance, and it's usual, more or less usual secondary effect, side effect, the visual dependency that happens in those patients. And it's because the sensory rewiring that have to be done in a lot of different situations isn't correctly done, no? So we are gonna maintain, like, in a demanding situation where visual information it's always needed, and we are not gonna do these changes between learning again and have more vestibular information to maintain this balance, no? And that's where vestibular rehabilitation also can really help with this motor learning of the situations. Here we can have a lot of different things that can affect us, like the sensitivity affectations maybe by diabetes, musculoskeletal pain, peripheral nerve compressions, etc., or mobility impairment like arthrodesis or like dysmetries, etc. No, and then we will have the visual impairments also that will strabism and blindness, for example, will be of course much more difficult to make it better. But all these variables will be not by their own. If we see the biopsychosocial model of medicine that's going up right now, it will be very important the psycho and social variables too, where all these compensations in the central system maybe can't be adapted as easily as it will happen in a better situation regarding the psychological and social variables. And a good example of this is of course the persistent postural perceptual dissonance. And at this point, exercise has also its own benefits. It won't be as a psychological or psychiatric therapy. Of course it should be done at the same time, but it's also true that exercise have its anxiolytic effects, have also antidepressant effects, and it can be just a plus in just something to sum up everything, to add to these effects, no? Something that can help. And finally, another different vestibular not properly going evolution of the pathology will be the vestibular decompensation, no? Because there will be a long-term recurrence of symptoms in some vestibulopathies, because the principle that we talk about, the use it or lose it, if they don't have much activity in their daily activities, if they don't use this improvement on motor learning, probably it will disappear, no? But until now we have seen the effects in physiology, in exercise, in balance, in pathology, but just unilateral. Just why? Because it's easier to understand, and it then can be extrapolated to a lot of different pathologies where those complexity are increased, no? So we will have all the implications of principles that we had told before, but we need to adapt it to the different pathologies that we will have in clinics, and with all the different variables. So depending on the moment, one principle will be more important than others. For example, when we have not just unilateral but bilateral vestibulopathy, the physiology implied in adapting the vestibulocular reflex will be a little bit different, and other physiology aspects as erythrocyte or central preprogramming or cervicocular contribution will be more important to be able to adapt this reflex to make it at least more functional in the daily activities. So our theory, it's going to be different, so our way of treatment probably will be also different to interact, no? To improve this patient, and also not just with the vestibulocular reflex but also with the equilibrium. So we will have that those patients have visual and synesthetic information depends. Those will have poor reactive balance, those will have residual vestibular information also, and in a different grades. And this is a very huge point for the bilateral vestibulopathy, because better prognosis after vestibular rehabilitation do better responses at high frequencies of vestibulocular reflex. To say, if we have more information that's still coming from the vestibular organ, we will have better rehabilitation outputs. And it's interesting to know how the rehabilitation is going to be focused, and of course to talk to the patient to know how long are they going to be in the process, and how the final situation could be, and as we had more or less adapt all these principles, well, we could go deeper, but not just in bilateral vestibulopathy. We are going to adapt, maybe doing more reactive balance, maybe trying to search for this vestibular residual information, changing the way that we are going to adapt vestibulocular reflex. Similarly, we are going to adapt those things, this knowledge, to the different pathologies in our clinic. It will be, of course, different to do the rehab process in unilateral acute vestibular pathology than in multiple vein syndrome, than in motion sickness, than in dizziness and unsteadiness post BPPV. It will be different in vestibular migraine. It's very interesting because the physiology of migraine also it's very, very complex, but we have also a good point, an interesting point with the vestibular rehabilitation. And similarly with the unsteadiness post BPPV, there's a lot of theories why they still having dizziness or unsteadiness, but between those theories, one will be the compensation of the central nervous system, and we will have a huge point there to improve those patients. And as we had been talking about, the older adult, of course, is a huge point that it's going to be going differently than others, but not just for the age, but also for the pluripathology that it's going to affect, and it's going to have a very huge variability between those patients. And even more with more neurological patients than canvas syndromes, multiple sclerosis syndromes, Parkinson's, or even, well, taking in consideration that others are going to go worse during the time, knowing where and when they have to do it. They have to do rehabilitation because they can also improve the quality of life. It's going to be a challenge. And also the stroke will depend, of course, in the huge variability of kinds and types of strokes. So choose how it's going to be the rehabilitation process. It's going to be really, really challenging. And here is where the clinical reasoning will makes also a huge point to focus the rehabilitation process more depending on the patient, depending on their activity, depending on their age, depending on the pathology, depending on a lot of different variables. And we are going little by little in this direction that make the vestibular rehabilitation process more individually for the patient. So thank you so much for listening to me. I hope that you enjoy a little bit. I hope that it had been really understandable. You have here my mail for any question or whatever that you will need. And thank you so much for listening.